So as we start to think about the management of the patient in general, we have to understand that we need to take the entire patient into context. And we know that the rate of progression of these patients is very important. And probably the best thing that we've seen in the last few years is the availability of antifibrotic therapies. And their key effect is in slowing that rate of progression. Now, what that does for us is it really changes some of the paradigm in regards to our ability to predict how they're going to do, because we don't know yet. Those drugs are so new. We don't know yet how they change the Kaplan-Meier curves of the data that we've had to date in regards to their value. We know that there's basically a 50% reduction in the rate of decline. And as we talk to them about their eventual outcomes, we incorporate that into the discussion. So when we talk about palliative care of these patients, we're really focused on improving their quality of life and making them understand what their longevity is going to be. And so when we tell them originally that they have a 50% 5-year mortality, that's based on data before we had treatments. And so somebody who would go 1 year now goes 2, potentially. And someone who would have gone 10 may go 20. The trap in that is when you're talking to an 80-year-old, ensuring 20 years is clearly a matter that's going to depend on numerous other factors. And so they have to take all of that into context. But our goal is to, as I tell them, isn't make them to live forever, it's to make them live better. And that really goes hand in hand with the palliative care of the patient. Now, the good news is that this disease doesn't carry a whole lot of pain or discomfort. And the result is that when we focus on the palliative care, it's really about making sure that their activities of daily living continue to be met to the best of our abilities. And one of the strongest elements for that is pulmonary rehab. And I often tease that pulmonary rehab is very much not dissimilar to my exercise program this morning. The more exercise I get, the more energy I had during the day, the more I was able to do, and the better I felt overall. And it's really true for these patients as well, and there's been a growing body of evidence for that. And so as we think about it, what happens is we help improve their breathlessness, their deconditioning, their sense of fatigue. That helps improve their social isolation, their anxiety and depression, and that really helps to empower and improve their overall quality of life. And realize that the rehab programs were originally designed for COPD, so that the irony is they often come to me and tell me about their kazoo, because in COPD we use a kazoo to help them in pursed lip breathing, which has no impact on this disease whatsoever, because we've sent them to a COPD program. But that's okay. It's really about the education and the exercise and the counseling support that matters so much. And so these programs are often run by respiratory therapists and physical therapists. And the idea, of course, is to teach them how to exercise themselves, with or without oxygen, depending on their needs, ultimately to improve their conditioning, to reduce their symptoms, and optimize their functional capacity. And as I pointed out before, increase their social participation. What's the evidence for that? There's very clear evidence that as long as they engage in the rehab, that they're going to have a training effect. They're going to improve their 6-minute walk distances. They're going to improve their exercise capacity. The heart and the lungs work together. And the more conditioned we get their heart, the less demand it makes on the lungs to deliver more oxygen while they're exercising. And that impact stays as long as they stay conditioned. But what about transplants? Well, it's very interesting. The truth of the matter is that IPF, after the lung allocation scoring system change in 2005, moved to the top of the list. And it became one of the major indications for lung transplant. And in fact, patients have been doing better and better. But it's important to recognize that it's merely one treatment, right? And it's only going to be available to about 1 in 20 patients with IPF, given the number of lungs that are available. And that it tends to carry 50% 5-year mortality also. What patients really get out of a lung transplant is a dramatic improvement in their lung capacity and therefore their exercise tolerance. So their quality of life goes up. So it's not to be taken lightly, but it is very, very important. What's the candidacy for lung transplant? Well, the truth is it should be considered in every patient with IPF as early on as possible. As I just mentioned, we have a high risk of death within the first 2 years, and certainly within the first 90 days. That's our highest risk group. And overall, it still carries a pretty high mortality over the 5-year period because of graft rejection. Early on, the problems that we see have to do with acute rejection versus chronic rejection. But if we're going to be able to transplant these folks, we need to get them to the transplant centers and to the transplant doctors as early in their course as possible so they can be in the best possible condition to undergo those transplants. And so the current recommendations and guidelines as of 2014 included histopathologic or radiographic evidence of usual interstitial pneumonia, an FVC of less than 80%, really just documenting that they have a restrictive disease, with a DLCO of 40%, and then any sense of shortness of breath or functional limitation. But the score really goes up as there's an increasing oxygen requirement. They purposely developed the score to weight it in favor of patients with IPF who have increasing oxygen requirement, even if only during exertion. What's the standard monitoring for these patients? I generally recommend that patients undergo pulmonary function test and a 6-minute walk test to elucidate their oxygen requirements every 3 to 6 months with continued evaluation of their comorbidities. That's really one of the key ingredients here, right? On the one hand, we're monitoring their disease. We're trying to figure out if we're having some success using the antifibrotics. But the other is the comorbidities matter. And the more that we're able to pick those up and treat them as appropriate, the better the patients are going to do. The HRCT, we do that really when there's clinical suspicion of worsening, looking for acute exacerbations, but more importantly, looking for secondary processes that we could correct.